This will be your lecture on your quality assurance and your quality control in diagnostic radiology. And we're going to look also at the hospital structure and how it affects radiology and why it's important in diagnostic imaging. So in order to really understand when we're doing our QA and QC, we need to look at the whole hospital as an organization because that's really who we're doing the QA and QC for. So also we're doing it for the Joint Commission. So I'm going to read you this definition because it's really important. So the Joint Commission is a private organization granted authority by the federal government to survey healthcare organizations in accordance with the Joint Commission standards and to deem the organization compliant with Medicare conditions of participation, so permitting them to participate in Medicare program and receive payment for appropriate services provided to Medicare patients. So without having the Joint Commission's gold seal, it's a lot more difficult to get reimbursed from Medicare. So that's Medicaid, Medicare, so anything to do with the federal government payments. So the Joint Commission accredits approximately 4,000 facilities here in the United States. They publish and survey hospitals for compliance, and the standards change and evolve as we find out more things for patient safety. And the hospitals are required to self-govern, just like you are for being a technologist. You have to self-govern, so you have to self-report. All right, looking here at this graph, you can see the Joint Commission International. There's also the Joint Commission Center for Transforming Healthcare and the Joint Commission. So in the middle is the patient, and that's really what they're doing is they're looking to make sure that we're providing a safe environment for patients through the hospital setting, through medical transport in the lab and primary care. So they look at the hospital as a whole. So the Joint Commission certification, so it's a checks and balance system. It promotes the accurate delivery of services, and it drives our efficiencies higher with broadening and enhancing communication between departments. So the big thing with the Joint Commission is communication so that the patient gets a continuum of care no matter where they're at. So we're going to look at the hospital structure. There's 6 different types of organizations. So there's a governmental entity, they're like the VA. There's a not-for-profit corporation, so most of the hospitals are not-for-profit. There's for-profit corporations. There's partnership, limited or general. There's limited liability companies, which you'll hear LLC all the time, and there's sole proprietorship. So special organizations can combine one or more of these types of partnerships. So a hospital can partner with a sole proprietor, and it could be a not-for-profit linking up with the doctor's office that's a sole proprietor, or the hospital could link up with an outpatient imaging center that is for profit. So there's a lot of combinations of different organizations. So who manages these facilities? There's a board of directors, so that's the governing body. There's the chief executive officer, and there's the medical staff. So let's talk about the board. They're ultimately responsible, and they have the authority of the facility. So they establish the goals and the policies. They select and hire the CEO. They delegate responsibilities and authority to the CEO to manage the day-to-day business. They appoint medical staff members. And if you don't know who medical staff is, those are the doctors that are contracted there at the hospital. They make up business people from the community, and they monitor quality of care and provide expert advice. They approve appointments to the medical staff or grant or decrease clinical privileges, and they monitor the quality of care for the hospital. The CEO has a very simple job description, but it is very vague, and they're responsible basically for everything in the day-to-day operations. So they manage the organization in accordance to the policies approved by the board. So that's their definition for their job description, but they do everything that the board tells them to do under the policies and procedures for that hospital. Medical staff, this is what they're responsible for. Facilitating communication among the medical staff members, implementing hospital and medical staff policies and procedures, recommending initial appointments and reappointments to the medical staff, and scope of clinical privileges to be granted. So if they have someone that they're working with that they'd like to get privileges, they will go ahead and submit that person to the board for approval. Providing continuing medical education and taking other actions necessary to govern the medical staff and to relate to the hospital board. So the physicians are organized into medical staff in order to comply with the Joint Commission standards. Credentialing. So anytime a doctor is working at a hospital, they have to be credentialed at that hospital. So we call that just credentialing. There's a whole department for each facility that has a credentialing department. So it's a process of determining eligibility for hospital medical staff, privileges granted to physicians and allied health professionals. So they will actually, the credentialing office will run our backgrounds and make sure that we are properly licensed for the job. So they look at your academic preparation, their licensing, your training and performance. Applicants always have the burden to prove that he or she is qualified and capable of performing the requested privileges according to applicable standards. So there's some legal cases where credentialing has failed. So hospital found liable for actions of physician due to hospitals should have never appointed that person to medical staff due to not checking professional credentials or references. So that's a pretty big deal if the let's say it's a radiologist read a bunch of studies incorrectly and they never really looked at the credentials of this person and never appointed him to medical staff. So the hospital that is then liable, the board of directors is liable. So Arizona court, hospital liable for failing to curtail the clinical privileges of a physician who had several bad results with a given procedure resulting in malpractice suits. So if there's a physician, let's say in the OR, an orthopedist who keeps having bad results, let's say he has high infection rate, or let's say that the patients keep suing for malpractice, the hospital and the board, when I say the hospital, I'm talking about the board, needs to take and counsel this physician and take away the privileges as needed. So licensing laws. Licensing is necessary to protect the public from unqualified practitioners, provides a status and expansion in the scope of practice, and there's certification. So private professional organizations sponsor programs to certify that individuals meet certain criteria, are considered prepared and practice in that discipline. So with us, our certification is from the ARRT, and it is what is known. So when we carry that certification, we just go in and show, yes, we are ARRT-Rs, which means radiography, and therefore we are able to work. Establish a scope of practice. So who makes a judgment that certain procedures will be performed and who is allowed to perform them. So that is our scope of practice. So they use the ART scope of practice typically for us to practice in a facility, but it can be limited from what is posted. How does this affect radiology? Okay, so if you look at the pyramid, normally there's the CEO, there's a couple vice presidents, and you have a bunch of administrators, and then a bunch of like chiefs or directors and supervisors, and then you have a bunch of workers here. So you have your professional worker, which would be us, and then you have your non-professional workers, which is your support team. So it's a top-down communication. It's usually in a formal manner. So policy changes state that you need to do this now instead of that. So top-down. When you have bottom-up communication, it's like playing the telephone game. Things get misconstrued. It's really important that if you're going to talk to your boss about something that you think needs to change, that you put it in writing, because what you said might get interpreted differently and relayed differently than what you initially wanted to happen. So, what is your role? And how is the radiologist fitting into that, and how does administration fit into that? So when you get a patient, each patient is completely different. We control over 25 variables. We have the x-ray equipment that we have to worry is working properly, and that's part of our QC. We need to look at the image and make sure it's acceptable. We need to make sure that it meets the criteria of our scope of practice. The radiologist is then responsible for that image. So they're responsible to read everything on that image. That's why we don't crop or mask or whatever you guys want to call it, because the radiologist is ultimately responsible for everything on that image. And as you know now, the administration has given privileges to the radiologist to be in the facility. So it's a top down. So the administration oversees the radiologist who oversees us, and we all need to work within our scope of practice. All right, so the patient. So as you know, there can be challenges in getting the images that you need to obtain. It can be from the emotional state or the physical state of the patient. Good communication is critical in order for you to get your images. And good physical conditions, so you need to be able to see the requisition or the order. You need to prepare the room. You need to explain the exam to the patient, and you need to let them know that you're going to be touching them. Is it okay if I touch your hip, as I need to center for your abdomen x-ray? And you need to make sure that the patient is comfortable as possible. So when you have management looking at you to evaluate you, they may come down physically and observe you while you're working. They're going to do patient interviews. So as the patient's leaving, they'll give them a card, or they'll just stop in the hall. When I'm in management, I'll stop patients in the hall and ask how their experience was and how Mandy did today. We'll also interview other technologists and find their input. So it's really important that you get the patient's perspective, the technologist's perspective, and also view yourself, because sometimes you can be biased or the text can be biased. So it's really important that you get the patient along with a multitude of other things to evaluate people properly. So our role. We need to look at the equipment and make sure the equipment is working properly. And we look at the equipment, the whole process, as making a diagnosis. So if you have consistently light films, you're going to have to try to figure out why you consistently have light films instead of going ahead and just jumping up your technique. There's a reason. So if you need to call in service personnel, you need to do that. All right. Orientation to the equipment and the procedures, so you have to be properly trained. You develop positioning skills, and that's what you're doing right now in school with us. And you need to select the appropriate exposure factors. And the most important thing here, after you've graduated, you need to maintain competency. Even while you're in school, if you shoot a portable chest x-ray and you got your competency, you need to be able to maintain that competency. And maintaining that competency just doesn't mean through school, it means for life. So important. All right, so as a technologist, you have near complete control of the quality of your images. So it's based on skill, your judgment. You need to look at maintaining the quality of the equipment through a quality control and also a quality assurance program. So exposure factors that you work with, you already know this. You have your KVP, your MA, your distance, your time, and AEC. So AEC can cause some problems. So if here's your center cell, let's say you have it on and you're doing a stomach. So you have your center cell on, you're centered perfectly here. So this image is going to be properly exposed of the stomach. Here you can see the center cell, we're off-centered a little bit, so we're not catching the stomach, we're just going to be catching, let's just say that's air, okay? So it's going to shut off too soon and give you a light image. So it's really important that you do your proper centering and know where your cells are so that you can get your proper technique. Okay, so quality assurance. So the radiologists and the technologists are typically responsible for the quality assurance, which actually goes up the chain all the way to the board of directors. So when I worked at one facility as a radiologist assistant, I was responsible for all the QA in the department, and I actually had to present to the medical board. So quality control, here's your definition. Techniques used to monitor or test and maintenance of the components of an X-ray system. The quality control techniques thus are considered directly with the equipment. So quality control is equipment. So the X-ray system components, so you have your high voltage generator, you have your X-ray control panel, you have your tube housing and assembly, your beam limiting device, which is also your collimators. You can use cones or whatever. Necessary support structures. So other components are imaging receptors, image processors, view boxes, and dark rooms. And we're going to cover all of the other components next semester, and all of these components next semester also. All right. So quality control, it's conducted by qualified staff or by qualified outside consultants. Typically now, most facilities have a licensed medical physicist that comes in. They're either on staff, like Scripps has so many facilities that they have a medical physicist that is on payroll for Scripps. It can be licensed technicians for like a service organization. They can come in, but a lot of the QA and QC on the, well, at least the QC on the equipment is supposed to be done by a licensed medical physicist. So, quality assurance is the planned and systemic actions that provide adequate confidence and that a diagnostic X-ray facility will produce consistently high imaging with minimum exposure to the patient and healing arts personnel, which is us. So, quality assurance program means an organized entity designed to provide quality assurance for a diagnostic radiology facility. The nature and extent of this program will vary with the size and type of facility, the type of examinations conducted, and other factors. So quality assurance of one aspect of radiology, let's say we're doing quality assurance of the processor. Under the quality assurance program, it will have of the image receptors, of the processor, of the view boxes, of whatever. So all the different QAs that we run are under the quality assurance program. So the radiologist is the most important aspect of QA. He's the only individual able to make a diagnosis. So they set the limits. So here you can see we have a light film, we have a dark film, and it's perfect here in the middle, and they draw the line. So when we talk about your EI numbers and are you in range, are you out of range, that's what we're talking about, is what the radiologist has determined. So if you look here, we have real narrow range compared to a really loose range. So how do you think the difference is going to be in your quality? So here, your quality is going to be very good. So if you have a real narrow range on your EI, so it's 100 to 200 for chest. I'm just throwing numbers out there. So 100 to 200. So this is right here, 100, and this is 200. That's only the range that you're allowed to be in to submit a film or a image. Your image quality is going to be pretty high. Where here, if this is 50 and this is 500 for the same chest X-ray, you can see that the range is really big and you're not going to have as good of images going to the radiologist. So try to get your range here. You want a real tight range. You don't want anything that's real loose. Your quality at your facility is going to suffer. Okay, so 15 means for achieving quality assurance. So a systemic approach, overcoming communication problems, consider all aspects of the patient, create good physical conditions, understand manager evaluations, importance of image processing, and beware of complexity of equipment. That's a fun one. And be familiar with your equipment. You need to have good positioning skills, good technical factors that you're selecting, assist in a range of department services, so you need to be well-rounded. Awareness of your limits, acceptable limits for each exposure, and that's an area that we're going to start harping on you guys next semester, that you really understand that your chest x-ray has to be between 100 and 200 or whatever it is. Awareness of department acceptable limits, so even though you didn't fall within those limits, you know that you have 10%, 20% on either side that you could probably still submit. High personal acceptance limits. So you want to have really high standards for your images, but you don't want to do it at the patient's expense. So some people will use double the exposure than what's necessary so that they have really pretty images. That's not what the goal is there. So you need to have really good standards within yourself and understand that, you know what, this isn't a perfect image, but it's a diagnostic image. I know what I can do next time to fix it. So you assist the radiologist in taking patient histories, and you need to provide the link of communication between the patient and the radiologist. So in image processing, as we talked about, there's the latent versus manifested image. So the latent is what's on the image receptor waiting to be seen, and the manifested image is the actual image that you can see. So there's the traditional film screen and there's digital imaging. Both require comprehensive quality control programs to maintain proper image quality. And typically the tech, we do it daily, sometimes multiple times a day if you're in mammography with film. All the way up to once a year. So it can be all over the board. And all of that contributes to your total quality management, your TQM program. So your quality management program has all aspects within it of your QC. So RTs use special tools to check the accuracy of the equipment, and various tests are completed from daily to annual. And a good QA program, so if we're looking at a QA program overall, we need to look at who's going to be responsible for making sure that we track everything. We're going to look at the purchase specifications. We're going to monitor and maintenance all the equipment to ensure that the patient's getting the proper exposure technique, and you're able to do your job efficiently. We look at the standards for the image quality. We look at evaluations, records, manual techniques. We do trainings. We also do manuals, policy manuals, lots of trainings. There's committees, and the big thing is to review the results and share the results with the staff. So quality assurance encompasses all aspects of the imaging, including customers. Quality control involves the technical equipment. It's required by law that we do it. So you are part of the team. You have to help us with the QA and QC, and it's part of our scope of practice. So that is your quality assurance and your quality control. I'll post a test for you soon.